for all the parts of our body in patients that have ALS. Now, as a lung doctor, I'm most concerned with the chest wall. And so we ask our patients to do breathing exercises, which you're going to see in a minute. We do want to start these as early as possible because of the preventive nature of what we do. And we'll frequently start with exercises like ambu bag and breath stacking, which we're going to talk about here in a minute. And we've already talked about the extra-articular contractures and the intra-articular adhesions. This is just a picture of what your chest looks like. And the reason that I wanted to show this picture is just to remind you that even though we think about joints in our body being the big things, like your shoulder, your hips, your knees, remember that every one of those in the chest wall is a separate joint. So as though we usually think of that as not an area with a lot of joint disease, it actually can be a place where it's tremendously important. And this is an example of physical therapy that can help with the chest wall. For those of you that know Mary Massery, she's a physical therapist who works with us at the Rehabilitation Institute of Chicago. And this is a demonstration of the exercises that she looks at, including, and what you can see her doing in this picture here, massaging the chest wall directly to help open up those areas. And that's why we do recommend PT and OT for our patients, not to strengthen their muscles, but to give them good range of motion. What you're seeing here in the far right is Stephanie Hesser. For any of you who have come to our clinic, she is our fabulous medical assistant. She actually runs the whole thing. You know, Dr. Heller and I just show up. Stephanie tells us what to do. And this is a video that she and I did because she actually took a week of vacation, and I said, Stephanie, how am I going to live without you? I have to videotape you. So we videotaped her doing the instructions on how to do breath stacking exercises with an ambu bag, and this is all up now on YouTube, and you can get links to it from our site. And basically you'll see on Stephanie's lap is a big silicone balloon, and she has a mouthpiece there. And we ask patients to do breath stacking. So that's breath in, don't let it out, another breath in, and you can feel that chest wall going out, you can feel those shoulders going back, and then you know you've done the right thing. Other things that we can do to exercise the chest wall, we can use a cough assist, and we have a picture of the Vital Cough, which is one of the ones that we use. That's that blue device at the top. We also have the T70 and soon to be the E70 cough assist machines. That's the one right here, and the gentleman who's in the wheelchair. And then we also use something called a therapy vest. And the therapy vest is right in the middle there with the picture of the child wearing it. There are modifications that we do for adults with ALS so that we have it easier to get on and off. It's called the therapy wrap. What I will tell you is picking which of the right of these devices matches the patient's need. That's the job of the pulmonologist, and we get to know our patients and decide which one of these therapies would be best for them. The next thing is to talk about not just how that chest wall works, but how it is positioned. If you think about your body as a Coke can, coughing and breathing works the best if the floor of the mouth is in 100% parallel with the floor of your pelvic bones, right? And that's why you can see two pictures of people in wheelchairs in this slide. One, you can see the patient is not very well seated and not very well supported, and they have that curvature to their back, which basically means the core muscles are ineffective. And that limits your ability to take in a breath and cough. You'll see our next patient here has good seating and positioning where they're upright as much as they can be, which helps to improve their ability to speak, to breathe, and to cough. So one of the activities that we really focus on in the clinic is looking at the seating and positioning of our patients, having a wheelchair mobility specialist look at our patients and make sure that they're in as good a position as they can be. Also, I don't have it on the slide, but we sometimes use abdominal support devices, which really is a back binder, but it helps to straighten that core. And we can use that for our patients as well to improve their ability to cough and really take that muscle activity and use it for breathing rather than misplaced use to support the core. Now, as we've talked about sort of our top of our head to the bottom of our feet in terms of how it works for breathing, what I'd now like to do is transition from day to night. And in night, we're going to talk about a lot of different needs for our patients. The first is sleep. And why do we care about sleep? Well, there's a bunch of factors. In dream sleep, muscles are naturally weak. That happens to everyone, you, me, everyone in this room. And that's good, because otherwise we would dream about a beautiful swimming pool and tend to jump off the end of our bed. The problem is, in patients who have ALS, those weakening muscles during sleep means that if we had trouble breathing beforehand, we would have a lot more trouble breathing when we actually get into sleep. There are also central or brain factors that occur as part of sleeping that also challenge our breathing. We all take smaller breaths while we sleep. We know that in patients with ALS specifically, there is occasionally a failure of the brain to tell the body it's time to take a breath. We call that a central apnea. And CO2 elevation occurs because of these changes in control of breathing during sleep much earlier than it does during the daytime. Carbon dioxide is a toxin that the body produces, and it's the job of the lungs to get rid of that toxin. And we know that if we don't wash the CO2 out of the body, it especially becomes toxic to muscle. In the research labs in the pulmonary division at Northwestern, we have animal models in which we expose the animals to high CO2. These are not SOD animals. These are not a specific ALS model. They're normal, healthy animals. And even in that situation, the higher the CO2 the animals are exposed to, the more myopathy and muscle wasting those animals get. So we believe that the use of interventions to reduce CO2 early are important, not just because we want to normalize numbers, but because we know that it is a specific way to treat and improve muscle function. So there are non-medical issues that we have to look at. And the first is to say, well, if you have terrible insomnia and you're not sleeping, you are not going to be able to have any of the therapies we'd like. So we ask patients to avoid naps during the day, especially those over 20 minutes. We encourage patients to be physically active during the day, even if that's just getting outside to get some bright sunlight, or engaging in social activities to keep your mind active. We want you to improve respiratory support by elevating the head of your bed while you sleep. And if anyone is told that they have an anxiety problem, we want to make sure that the reason that that isn't there is just because they can't breathe. We don't want to say that this is an anxiety issue unless we prove that the breathing is adequate. We encourage patients to do lots of stretching. We've talked about this. And we've asked patients to do mind clearing exercises to allow them to rest and sleep so that they can use the therapies we want to help clear CO2 out of their system. And frequently we have to work on these relaxation exercises, and that's one of the things if our patients are being seen by an occupational therapist, if they're being seen by one of our social workers like Easton or like Lori Fieldman, that they can go over with you in the home, and they have been doing that with our patients. Medical treatments that we use at night address issues of pain and spasticity. They address saliva. We already talked about how amitriptyline can help. And we do look at using medications to treat insomnia if we have to. In the older generation of sleeping medications, we couldn't give them to patients with ALS because they impacted their breathing. Newer medications, we call these the Zs, zolpidem, zaloplan, esclopidine. They have brand names like Ambien and Lunesta and Sonata, which you're probably more familiar with. Also Ramelteon, which is a medication based on melatonin. All of these are much safer for our patients because they don't impact the ability to breathe. When you're sleeping, if you do need ventilation options, we offer two kinds of options. Those that are called non-invasive and another group that is called invasive. Non-invasive ventilation uses what's called a mask interface. And by mask, we mean anything that goes on the face, allowing us to support breathing by blowing air through the nose, through the mouth, or through both at the same time. We recommend starting early based on data, which shows that if you start based on lung function tests rather than symptoms, you can significantly slow progression of muscle weakness and reduction in muscle function. And I'll tell you that slowing and the reduction could be the difference between 18 months based on the data that we've seen so far. And the other thing is that the sleep testing that frequently is recommended to patients with ALS is not a need to. We can often start this therapy just empirically after what we have done with lung function testing in the office, meeting our patients, examining them, and doing lung function tests. It's super important to know this because non-invasive ventilation for many places around the country, patients are told that they need to wait and have a full sleep test where they come to the hospital and they have to be examined overnight. The reality is that's not needed, it's not necessary. And the other reality is most outpatient facilities are not set up for the needs of those with disabilities. And so it frequently becomes a stumbling block, something that limits ability to get care for patients. And so we do not use this as a way of initiating therapy. Oftentimes you will also hear about something called invasive ventilation. Invasive ventilation requires what we call an internal airway or a tracheostomy, which is a surgical procedure that puts a permanent tube in the throat. These increased costs and increasing cost limits the availability of caregivers. It may increase infections and will not stop the progression of ALS. These kinds of devices look like the following, and we have some pictures here. The lady up here, right over there, is using a standard, what we call a RAD, or a respiratory assist device for non-invasive ventilation. She has an interface that's just going through her nose, and it is comfortably at her bedside. The gentleman in the picture next to her, has a tracheostomy tube, and you can see that there's a tube in his neck there. And he's using this connected